Good morning, everybody. Good afternoon. Hello. And thank you for joining us today for the Elizabeth Glaser Pediatric AIDS Foundation World AIDS Day panel discussion, which is titled Addressing Inequities in the Global AIDS Response in the Era of COVID-19. My name is Rhoda Igweta, the Associate Director for Public Policy and Advocacy here at EGPAF, and it is my pleasure today to moderate this conversation. Before we start the program, I want to offer some housekeeping notes. Because of the high number of attendees, everybody's audio will be muted. This event is also being recorded and will be made accessible after the event on EGPAF's website at www.pedaids.org/World AIDS Day 2021. If you have any technical issues or questions, please message Manish Lal directly in the chat feature of the event or via email at mlal@pedaids.org. For over 30 years, the Elizabeth Glaser Pediatric AIDS Foundation has been dedicated to improving the lives of women, children, and families affected by HIV and AIDS. Our work spans to 20 countries and includes significant programmatic research and advocacy efforts that are changing the way service delivery for children, youth, and families happens in those countries and around the world. Inequality is undeniably a main driver of AIDS and other pandemics around the world. Achieving an AIDS-free generation will require us to confront the inequities facing children living with and affected by HIV, a daunting task, especially in light of the massive challenges posed by COVID-19. The impact of COVID on the global AIDS response cannot be underestimated, particularly when it comes to children and youth. The sad reality is that since the advent of COVID, over 2.3 million children have lost one or more primary caregivers to COVID-19. On top of that, the Global Fund has reported that HIV testing and HIV prevention services dropped by 12% and 11% respectively when compared to figures from 2019 in countries where they are active. Since the beginning of COVID, UNAIDS indicates that over a dozen countries have reported decreases of 25% or more in prevention of mother-to-child transmission PMTCT services. These are figures that we simply cannot ignore. Today, we are very pleased to host a panel of global experts, leaders, and advocates who will share their vision of what is needed to end the inequities that stand in the way of an AIDS-free generation in the COVID era. After their presentation, each speaker will introduce the next panelist. After each speaker has spoken, EGPAF President and CEO Chip Lyons will moderate a dynamic question and answer session before closing the program. On that note, I am very pleased to kick off today's program with a special video from California representative and longtime public health advocate, Congressman Ami Bera.
Hi, I'm Congressman Ami Bera from California's 7th Congressional District, the Sacramento suburbs. I'm also a physician by training. I want to thank the Elizabeth Glaser Pediatric AIDS Foundation for the tremendous work that they've done over the years. We still have work to do. Programs like PEPFAR have been tremendous benefits in trying to eliminate AIDS and find cures for diseases like HIV, as well as tuberculosis and malaria and others. We have to continue making these fundamental investments as the United States and continue to work with countries in Africa to both address the AIDS challenge, but also address the impact of COVID-19. I look forward to continuing to work with the Elizabeth Glaser Pediatric AIDS Foundation to make sure we have a healthy, more prosperous, and stable future in the 21st century. Thank you for your work. Be well, be safe, and let's be kind to one another.
Our next speaker is global health expert and Acting US Global AIDS Coordinator, Dr. Angeli Achrekar. Throughout her career, Dr. Achrekar has dedicated herself as a public servant to global HIV, AIDS, women's and girls' health, and global public health development. Over the past year, she also faced the unexpected task of shepherding the PEPFAR program through unprecedented challenges posed by the COVID-19 pandemic. Please join me in welcoming Dr. Achrekar for her remarks on the US response to AIDS in children and youth. Welcome, Dr. Angeli.
Thank you so much for that introduction. And let me first start by thanking the Elizabeth Glaser Pediatric AIDS Foundation, not only for hosting today's important event, but really for the years and nearly decades, multiple decades of partnership we've had together in working across countries to implement PEPFAR's programming. So a big thank you. Also, I'm really privileged to be here today to talk about PEPFAR's response to AIDS in children and youth. And on the next slide, I'd like to the next slide, please. Thank you. Just to reiterate what Representative Bera noted, just the incredible investment and leadership by the Congress and presidents across the many years since PEPFAR's inception in 2003. That unwavering bipartisan congressional and presidential leadership of PEPFAR has been instrumental. We've been so grateful for that support and leadership, and it has been critical as we charge through addressing both the HIV pandemic, but also what is before us in terms of COVID-19. On the next slide, please. I'd like to provide a high-level summary of the program status through COVID-19. I'll go into some details with data, but wanted to just give you a sense of how important the real-time program adaptation has been through COVID-19 to really ensure that we're both protecting the HIV gains, but also accelerating those gains while responding to COVID-19. What we've been able to show together because of the work, the incredible work that you've been doing across countries and communities, is a resilience in the face of COVID-19. We've preserved and increased our HIV treatment. While we've seen some challenges in testing and prevention, we've seen recovery of those services, and we've seen some important services scale rapidly, including self-testing, multi-month dispensing, decentralized drug delivery, and pre-exposure prophylaxis. This has not been without additional costs that we've incurred through COVID-19, but that has been essential to provide safe HIV services as well as respond to COVID-19. We've been nimble and shown that it's possible to leverage the health system infrastructure that we've strengthened together over the 18 years. And this is critical, particularly as COVID-19 persists and we continue to face health and economic challenges. On the next slide. As many of you know, we've been adapting the programming and leveraging our platform to protect HIV gains and respond to COVID-19. And I'll talk a little bit about what this looks like on the ground. On the next slide. We've been able to protect and accelerate HIV gains by emphasizing squarely on convenient person-centered care. We've adapted the program with your support to protect populations most at risk for poor COVID-19 infection outcomes. Some of these adaptations include maximizing continuity of treatment before lockdowns, really ensuring that we have a strong patient tracking system in place to ensure that we are establishing and maintaining contact with clients. We have really pushed forward, and I want to commend the governments for pushing forward on multi-month dispensing and to ensure continuity of care. We've seen the acceleration of 3 and 6 months of multi-month dispensing for the clients that we serve in unprecedented times through COVID-19, and this has been critical to really ensure that continuity of service. Decentralizing drug delivery, getting as close to the community and the people we serve as possible has been critical. And using virtual platforms for a number of different services, prevention and treatment services, has been core to the program. And I think the most important is local and community partners. Community-led monitoring has been critical as we continue to move forward through COVID-19, as well as working directly with community health workers. Next slide, please. This is a snapshot of our latest program global results, and this is as of fiscal year 21 quarter 3. We'll be releasing our end of year data in just a couple of days here around at World AIDS Day on December 1st. But we have been able to move together with you to ensure an additional 1 million people on treatment, if not more, throughout COVID-19, with 18.4 million people, men, women, and children on life-saving treatment, with over 2.8 million babies born HIV-free. We've continued to accelerate on our circumcision to prevent new infections among young men and boys, with 27.4 million circumcisions having been completed, and over 6.7 million orphans, vulnerable children, and caregivers have been provided with critical core services. On the next slide, please. This gives you a snapshot again of our quarter 3 results and the percent of the target achieved. So what you can see is that with testing at the top, we've already, as of quarter 3, exceeded our target with over 45 million tests having been completed. With our positivity at 77% of the target. Again, this is where we should be at quarter 3 results. We've seen treatment new among new clients at 74% of the target. And again, as I noted earlier, 18.4 million people with cumulative on treatment. The concern here is prevention of mother-to-child transmission. You can see 57% of our target having been achieved at quarter 3. So we really have to double down here. What is core is always looking at where we're going and where we're headed in terms of outcomes. So we look at viral load suppression and coverage, and we want to be in that top right quadrant there. And you can see where countries are at the end of quarter 3. Next slide, please. This is a very brief graphic that really just shows how together we have maintained our HIV treatment continuity and grown despite peaks in COVID-19, which you can see in the colored graphs and the waves that you can see. And then in the red line, those currently on treatment that has continued to grow throughout time. Next slide. What has been core is really determining how we can both sustain those HIV gains while also responding to COVID-19. We often talk about the PEPFAR platform. This is a care delivery platform that has, with your help, been established and strengthened for HIV over the past 18 years, but has been critical to both HIV but also COVID-19. This includes strong US government teams and relationships with country governments and communities on the ground, and implementing partners, including local implementing partners, among which EGPAF is one. We've invested heavily in health systems over the years, over $15 billion US, and this has resulted in strong laboratory networks and systems, data with infrastructure improvements across 70,000 healthcare facilities, nearly 300,000 healthcare workers, including nurses, doctors, community health workers, and robust supply chains that exist. We've been working together with you to proactively leverage these platforms to support COVID-19, everything from testing to vaccine readiness and administration. Our secretary recently said it clearly, with a speech that he had given on the continent of Africa on November 19th, where he says, PEPFAR has saved millions of lives, brought the world to the edge of the first AIDS-free generation, and transformed public health infrastructure, where the investments we made years ago in labs and clinics formed the backbone of this nation's COVID response. Next slide. What is concerning, however, are the challenges that persist in terms of sustaining epidemic control of HIV, including inequities that we see among children, among adolescent girls and young women, among key populations, and the devastating impact that COVID-19 continues to have across the program as we move forward. We also see key opportunities to really tackle inequitable access to health services across sectors by working across various ministries of health, finance, gender, education, social services, and others, with a real dedicated focus on some of these targeted populations is key. And a renewed country engagement will be critical as we move forward. Next slide, please. So as we move into the future, PEPFAR has included a new equity pillar to complement our work on accountability, transparency, and impact, a real focus on equity to demonstrate effective efforts to tailor services, close gaps, and address barriers faced by people most vulnerable to HIV, including children. Next slide. We must continue to ensure that resources are allocated with an equity approach to close gaps in pediatric HIV care. We are concerned around persistent challenges that exist with maternal to child transmission, with gaps in pediatric treatment coverage and gaps in pediatric viral load suppression. And we are really looking to bring additional resources to help close these gaps in pediatric HIV. Next slide. We're particularly concerned around 13 countries that account for 75% of the global HIV treatment gap for pediatrics. You know, especially among South Africa and Nigeria, and that account for 30% of the children living with HIV that are not on treatment across the globe. Next slide. So we are we're bringing an additional focus to really work together with all of you and our multilateral partners, communities, and governments to reduce new child infections in children less than 10 years of age by 50%, to address gaps in the prevention of mother-to-child transmission programs, to identify, link, and treat children not yet on ART and those that are lost to care, to increase rates of pediatric viral load suppression to 95% and reduce mortality. Next slide. We've seen viral load suppression is improving for some children living with HIV and that are less than 15 years of old, particularly the older children, but more progress is needed, particularly among the youngest. And on the next slide. So finally, just to note that we are working together to really push forward on pediatric dolutegravir. This is critical. We need to move with countries now. Next slide. We continue to follow the clinical recommendations for transition to dolutegravir-based regimens. And on the next slide, we've seen important positive movement with multi-month dispensing and scaling among the pediatric populations, as you can see in the last 3 quarters in this fiscal year alone. We can't revert back. We need to continue to push forward. Next slide. And so the final slide, just to close the gaps for children and adolescents living with HIV, we're doubling down. We're taking an extra special focus to set goals, objectives, and targets for eliminating vertical transmission and ending pediatric AIDS. We're bringing a dedicated focus for these services with dedicated resources and human resources for health, strengthening our monitoring and evaluation of these programs, ensuring adequate resources, as I noted, to make sure we're achieving toward these pediatric targets. And we're using case management and socioeconomic support to really move these outcomes forward. And what's key is also using pediatric community-led monitoring to track where we're headed for children and family-centered care. I'll stop there and just say thank you. And with that, I'd like to take this time to introduce the next speaker. It's my real privilege to introduce the National PMTCT and Pediatric HIV Care and Treatment Coordinator at the Zimbabwe Ministry of Health and Child Care, Dr. Angela Mushavi. She is an expert in vertical HIV transmission. Dr. Mushavi has long been involved in policy formulation and guideline development, both at national and international levels. A longtime advocate for the care of children affected by HIV, and we're so honored to have Dr. Mushavi with us today. Dr. Mushavi, over to you.
Thank you very much, Angeli, for the kind introduction. Allow me to greet you all. Good morning, good afternoon, and good evening. I'm looking at the title, as you can see on the slide, Ending Pediatric AIDS on the Continent. What will it take? And of course, being on the African continent, my presentation will most probably also focus a lot on the African continent. In the next slide, you will see from our data that, we have almost, before I go, let me just go through the outline. Yes, the outline of the presentation, thank you, which will look at the global and regional HIV epidata, some of the drivers of these new HIV infections among children, and the inequities in the 95 targets for children, some of the impact of COVID-19 on children, and then recommendations for tackling this problem on the African continent. You will see that is coming globally. Next slide, please. Million were living with HIV in 2020. 1.7 million of those were children between the ages of 0 to 14. And what is striking about that? What is that children, the African continent? We continue to see new HIV infections among children, where in 2020, we expected to have 20,000 new HIV infections in children. We still see that number sitting at 150,000. When you look at the ART coverage globally, you see a clear disparity there. 74% of adults living with HIV were on ART in 2020, against only 53% of children 0 to 14 years. And yet, we have a global 95%. Even for eliminating mother-to-child transmission, where we want all pregnant women on ART at a minimum of 95%, we are still seeing a global figure of 84%. And I know we have the Start Free, Stay Free, AIDS Free global report that clearly articulates some of the challenges we have, particularly with the focus countries that are here on the African continent. Next slide. We've also seen, when we look at the African continent, that there are clear disparities by geography and population. So while 95% of pregnant women in Eastern and Southern Africa region we're accessing ART for PMTCT in 2020, this figure drops to 56% in West Central Africa. While 57% of children living with HIV in Eastern and Southern Africa were on ART, only 35% received ART in West Central Africa. Clearly, you can see the differences in the geography and the population, even for children. So the tap is leaking and new HIV infections in children are continuing. And yet we know we have the tools and the means to prevent vertical transmission. And we also have the new UNAIDS global target to reach 95, 95, 95 targets for children and adolescents. Next slide. In the next slide, looking at the map of South Africa, of Zimbabwe, we have a population of 16 million people. We have an HIV prevalence of 11.4% in our country, but transmission rate is still sitting at 8.7%. So out of a population of 58,742 pregnant and lactating women, we are managing to initiate only a portion of them, 87% coverage. Actually, this figure is a drop from 2019, because in 2019, 91% of pregnant women who needed ARVs because they were living with HIV received ART. And that dip was really because of COVID. And again, even for adults in Zimbabwe, 94% are receiving ART, while only 73% of children are on ART. To continue in the next slide, we can see in the next slide that we have this stacked bar, which has been produced through the UNAIDS Spectrum team, working with our countries respectively. And at the top of the left stack bar is the mother-to-child transmission rate for Zimbabwe, which is 8.7% in 2020. And on the top of the right stack bar is the mother-to-child transmission, is the number of new HIV infections among children in 2020, which is 5,113. Now, in the color coding, you see in red, either at the top during the breastfeeding period, at the bottom during the pregnancy period, that a majority of infections driving the mother-to-child transmission rate are amongst women who did not receive ART, either during the pregnancy or the breastfeeding. In the lighter color, at the bottom, during the pregnancy period, mothers actually dropped off ART. And at the top, in lighter color, you see again the proportion of mothers who dropped off ART during the breastfeeding period. I want to highlight in the lighter brown color, the proportion of new HIV infections that are happening in women during the pregnancy period or during the breastfeeding period when they were initially negative and they seroconvert. And those three things combined are creating a challenge for the country in terms of tackling new HIV infections. Now, in the next slide, you will see how we think that we should tackle that. The solution is not doing business as usual. When we unpack the stack bar, and again, looking at the stack bar on your left at the top with the number of new HIV infections and the mother-to-child transmission rate, simply by removing the reds, having women on ART, having women initiated on ART, initiating creativity and innovative solutions such as pre-exposure prophylaxis will reduce new HIV infection on your extreme right in the bar to 883, and the mother-to-child transmission to 1.58%. So there are some key interventions, and you see them in the bubble on the right. Really, we need ART for all HIV positive pregnant and lactating women. We know now that the postpartum period is contributing quite significant new HIV infections among children. And we need innovations to scale up retention and adherence in viral suppression in pregnant and lactating women. And importantly, especially when we look at adolescent girls and young women and those that are less than 30 years, we need to target with pre-exposure prophylaxis to those that are at high risk of acquisition of new HIV infections. I'll go to the next slide and look at the issue on treatment, pediatric ART, in the next slide. we begin to see, as has been articulated by Angeli just previously in the previous presentation, that out of the total need for pediatric ART in blue, for my country, you will see 2015 moving to 2021 on your right, that the pediatric ART coverage is not meeting the need. So in the 9 months, January to September of 2021, 66% of our children 0 to 14 were on ART. Of course, we have another few months to go before the end of, a few weeks to go before the end of December. So we will know the 12-month ART coverage. But basically, you see, we have not made much of a great movement. Next slide. And in the next slide, when we look at the trend for pediatric ART, the green being adults, and the orange speaking to pediatric ART coverage, you see the disparities there. We're almost reaching 95%. In fact, the last ZIMFIA for our country in 2020, we have reached the second 95 by putting 95% of adults in need of ART on ART. So for adults, we seem to be doing pretty well, but for children, we are letting our children down. We have done and conducted COVID-19 impact assessments where we've actually noticed that between 2020 and the second assessment that was done in 2021, we're really failing our children in terms of pediatric ART. Next slide. So in the next slide, what will it take to end pediatric AIDS on the continent? Of course, we need to be focusing even pre-conception. We need to start addressing the issues of family planning, especially to adolescent girls and young women. We need to scale up pre-exposure prophylaxis for those at high risk of HIV acquisition. And you will see that those are the age groups of the younger women. We do case reporting in our country. We enter data for all children that test positive. And we are finding that upwards of 50% of new HIV infections are to mothers between the ages of 10 to 24, including those that are less than 30. We need to address our interventions to that subpopulation. And of course, be creative in supporting retention and adherence. And again, we have found peer support systems such as the Young Mentor Mothers, very effective at reaching other women or young girls who are HIV positive, being supported by other moms, young moms who are also HIV positive and have successfully negotiated the PMTCT Cascade. Viral load monitoring in pregnant and breastfeeding women is a priority, as well as, linking our HIV exposed infants to early testing and early ART initiation. Here in Zimbabwe, we received support from implementing partners to scale up point of care diagnostics. And we have found that having HIV testing, PCR testing on point of care really increases the turnaround time and reduces the time to linkage to ART. And now we have neonatal ART that is using optimized regimens with raltegravir. And we need to deploy point of care viral load testing as well for the pregnant and the breastfeeding women. And like what has been just articulated, a priority population for viral load should be children and adolescents, because as we have heard, their viral load suppression is less than that for the adults and for the older children. And targeted testing, while it is important to have early diagnosis, we see that 2/3 of the children not on ART are between the ages of 5 and 14 years. And we need to use other entry points to reach those children, including utilization of family index testing and use of community cadres that can find the missing children out in the community. And in the next slide, of course, we must not forget the current concept on deploying differentiated service delivery models on the MCH platform to track mother-baby pairs and document final HIV status at the end of breastfeeding, as well as strengthening community clinic collaborations, tackling advanced HIV disease, because even now we have children that present with advanced HIV disease, and we need to scale up even CD4 testing so that we can make early diagnosis of HIV, advanced HIV disease, and manage opportunistic infections. And from the previous presentation, since the advent of pediatric DTG, we recognize that we can end inequities for children by making sure that we rapidly scale up provision of pediatric DTG to children so that children are not left behind. And of course, I did allude to the importance of tackling DTG and not forgetting, of tackling COVID-19 and not forgetting that we do need to make sure service is not disrupted. And lastly, timely switch to second line and third line regimens as our children become more treatment experienced. So thank you very much for your attention and for listening. And at the end of this slide, I would like to take this opportunity to really introduce our next speaker, Dr. Judith Kose. As we have already heard today, COVID-19 has significantly impacted the global HIV response. And now, as I introduce Dr. Judith Kose, she is EGPAF's Associate Director of Pediatric Services, and she will talk at greater length about the way COVID-19 has affected EGPAF's work to create an HIV-free generation. And of course, she's an expert in pediatric HIV, in TB, and other comorbidities and at EGPAF. So Dr. Kose provides strategic direction for improving HIV services for children. And so may I take this honor to introduce you and bring you on, Dr. Kose, as I step off and go back to muting. Thank you.
Very much, Dr. Angela Mushavi, for that introduction. Good afternoon, good evening, good morning to everyone, wherever you are. And I want to thank the organizers of this great event. So as Angela mentioned, I'm going to take over from her and move on to talk about what we are doing at EGPAF to address the deep disruption of COVID-19. Next slide, please. So basically, just as a quick outline, we will look briefly to see where we were before COVID. And I think, Angela, you already talked about a lot of where we were before COVID, some of the effects of COVID, and really focus on what EGPAF is doing to respond to COVID-19. Next slide, please. So just to start with, I'll start with this quote that I like from an American poet called Maya Angelou. And it says, you can't really know where you're going until you know where you have been. And what really that means for us today is that we are looking at where we were before COVID, the effects of COVID, and having known that, that will guide how we move forward to address the disruption of COVID. Next slide, please. And so a good place to start is the new infections. Please, if you just continue clicking till I think it has some sort of graphics, continue. One more, I think. Thank you, thank you. So a good place to start, and we are talking about ending pediatric AIDS, which means, eliminating new infections. And there has been a significant decline in the new infections since 2000, but in the recent years, we have observed some reduction. So the greatest decline, which was a good thing, was around 2004 to 2012. But since 2015, the decline has slowed down. And as you can see there on the right, we were unable to meet both the 2018 and 2020 target. And this slowing down has been worsened by COVID. And it is thought the reason for this slowing down, and Angela, you already alluded to this, is the low ART coverage among pregnant and breastfeeding women, which has essentially been flat since 2015. It has to do with new HIV acquisition during pregnancy and breastfeeding, and also poor retention in care among pregnant and breastfeeding women. And so to address these, like Angela mentioned, there needs to be effort to focus on these reasons so that we can try and reduce further new infections in children. Next slide, please. So the other element to look at, and again, Angela, is like we were speaking to one another, you already alluded to this. So looking at the number of children on ART, since 2010, the number of children, the ART coverage among children has doubled. But as you can see, we missed both the 2018 and 2020 targets, and treatment coverage in children in 2019 was at 53% compared to 68% in adults. And in 2020, for adults, the ART coverage jumped to 74%, but for children, it remained at 53%. And so you can see there's a lot of disparities around treatment coverage as well. And I think there's still really need for strategic effort around identifying children to put them on treatment, linking them to treatment and ensuring that they are put on the correct ARVs in order to improve the pediatric ART coverage. Next slide, please. And so when you consider the effort around children, there's still a lot of inequitable efforts for children and outcomes, so that children are 40% less likely to be on treatment as compared to adults. And we also have disproportionate outcomes such that while children form only 5% of all people living with HIV, children account for 15% of all AIDS-related deaths. And as you can see on the graph on the right at the bottom, the deaths among children aged 0 to 9 years is much higher as compared to the adolescents who are 10 to 19. And so this is something that still needs to be addressed moving forward. Next slide, please. And then COVID happened. And I think this is something that we can't really miss out in any presentation in this time and age. And so I like this slide. It talks a lot about the closure of facilities, the exhaustion of healthcare workers. You can see the healthcare worker in PPE who is exhausted, he's probably lost a patient, the introduction of face masks, working from home and studying from home. But also I can see the middle, and that's my favorite picture. You can see a flock of sheep sauntering down the streets because the streets are empty and there's room for the sheep to walk. And so this really changed a lot of things in the world. Next slide, please. But coming to children, while children may not be the face of the pandemic, I think they're at risk of being among the biggest victims. So there really has not been much focus on children. And so now we are beginning to unpack the double trouble, and the double trouble here is HIV and COVID-19 in children. There's now effort to try and unpack this trouble. And so looking at the direct effect of COVID-19 infection among children, the COVID-related disruptions to the MCH services, be it vaccination, healthcare service delivery, and also COVID-related disruptions of HIV services. And all these will affect the health and well-being of infants and children living with HIV. And so as we begin to more and more unpack this trouble, the questions to be asked are, what parts of the Cascade continuum are most affected by COVID-19 disruptions? Have countries been affected equally? Are pregnant women and children more affected by the disruptions? What are the mitigation strategies? And what next? Because, I believe COVID is going to, get to a different place. So what next after this pandemic? And some of these mitigation strategies we'll be discussing in the subsequent slides. Next slide, please. And so this slide talks about, and it also has some animation. So while we have said previously, and I think, Angela, you also shared the same, that the new HIV infections have been decreasing over the last decade, the impact of COVID is perhaps reversing this progress. And so this slide shows the effect of the COVID-related HIV services disruptions on HIV outcomes among children, and comparing this by the percentage of the population affected. So if you could just continue clicking till the second graph comes. But basically, to explain what this graph looks like, it's talking about, so it compares as more and more of the population is affected by the disruption in HIV services, the outcome for children becomes worse. So as more and more population are affected, 50% affected or 100%, then the rate of new HIV infections become higher. On the other hand, similarly, as you have more and more population affected by HIV service disruptions, we have more and more AIDS-related deaths. And so this links the disruption of COVID or COVID-related HIV services to poor outcomes in children. And so when you address HIV-related services for COVID, we need to address it while considering that it's going to also affect the outcomes in children. Next slide, please. So at Elizabeth Glaser Pediatric AIDS Foundation, we are actively engaged across the COVID-19 cascade. So we are supporting COVID testing and surveillance in our countries in Lesotho, Cameroon, Kenya, Zimbabwe, DRC, and Malawi. We are also supporting work around integrated COVID care and treatment in Tanzania, Cameroon, Kenya, and Zimbabwe. And we are also supporting the uptake of vaccines in Malawi, Lesotho, and Uganda. And added to that, we have a research drive to try and understand and build evidence on COVID-19 integration and management across our 7 countries. And on top of that, we are also supporting mental health and psychosocial support for frontline healthcare workers and their families in Eswatini. And I will speak a bit more to that in a subsequent slide. Next slide, please. And so at EGPAF, some of our early response to COVID included virtual support. So this was not just for planning and implementation of services, but also doing surveys. For instance, the survey we did with the Kenya for adolescents and youth to understand the landscape and feasibility of virtual implementation. We also supported making adherence and treatment plans continue in light of facility closures, trying to scale up multi-month dispensation of drugs, including for children, and here trying to focus on children between 2 and 5, because older children were already covered for in terms of multi-month dispensation. We also supported the physical distancing and decongesting of facility, so helping facilities to space out clinic visits, moving the psychosocial support to virtual platforms, and also adopting decentralized services delivery models, such as community ART groups and community ART dispensation. We also support facilities to ensure that despite disruption of services, such as gender-based violence support, PMTCT and HTS, these were continuing using other models, but also sharing information with our peers and other facility staff on COVID integration to ensure that the professionals, that the staff are well updated, but also ensuring services are continuing within facilities and communities. Next slide, please. And so I want to speak quickly about a couple of examples of EGPAF's COVID response activities. Next slide. So the first is in DRC, where at EGPAF, we were supporting COVID-19 testing in collaboration with African CDC and MOH and other stakeholders. And some of the achievement in this work, including support the adoption of the national guidelines and training manual on the use of the SARS-CoV-2 antigen detecting tests. We trained both national trainers and also training of end users on the COVID rapid G testing. And like I mentioned, this was done in collaboration with major stakeholders, including MOH. Next slide, please. The other one I want to highlight is our work in Lesotho to support the vaccine rollout. So the work involved, working around the concept note for deployment of COVID-19 vaccine, including integrating the vaccine into existing service delivery platforms, supporting the use of the vaccine in mobile services at border posts, in factories, and in tertiary programs where we have HIV services, as well as integrating COVID vaccine uptake in our ART, MNCH, and TB clinics at health facilities. And we are also supporting the HIV programs in terms of integrating HIV and COVID as well as TB and COVID within the facilities where we work. Next slide, please. The other one I alluded to was our work in Eswatini, and this was basically supporting psychosocial support and mental health for our frontline healthcare workers. And as you know, COVID has had a huge impact on the healthcare workers. Not only has it led to the loss of healthcare workers, but also affected them psychologically and even, the services rendered. So some of the support we were giving under this effort in Eswatini included training healthcare workers and sharing up-to-date information on COVID integration, and how it affects the healthcare workers. We were able to revamp and improve the utilization of wellness corners for psychosocial support for our healthcare workers, as well as improving the services provided. And these services were both for curative, preventive, and rehabilitative services. Next slide, please. And so moving on, we are continuing to mitigate the effects of COVID while also harnessing the lessons. This is considering the fact that we know that the impacts of COVID will reverse the gains that we have made, knowing that the control measures and results in reduction and in access could mean that fewer children are able to receive their life-saving treatment. And so the two areas we're focusing on is using the virtual space. And so we are implementing pediatric case management. For example, our project in Lesotho is doing this. We have adopted in many of our countries virtual adherence counseling. And this basically means providing the counselors with an approved script that they can use virtually when they're offering adherence counseling to the caregivers or even clients. We have adopted widely the use of WhatsApp group for PSS support, especially among our adolescents and youth. And we continue to use remote facility support through cell phone and the WhatsApp. And we are also modifying our services. Like I mentioned, the use of multi-month dispensation of drugs while monitoring the stock and ensuring the facilities have enough stock, as well as integrating TB and COVID through the use of an integrated algorithm, adoption of tools, and also using of the dashboard. Next slide, please. And so I think this is really my last slide. And in summary, what are we saying? So we know that pediatrics are still left behind on all fronts, be it in identification that leads to poor coverage, poor linkage to treatment, access to ART, as well as achieving and maintaining viral load suppression. We know that there's continued disparities in HIV treatment coverage among children as compared to adults. Retention in care remains a challenge, not just for children, but even for pregnant and breastfeeding women. And this affects, new infections that we are trying to address. And like has been alluded, COVID-19 has reduced some of the gains we have made. And so COVID-19 services will continue, and they need to be integrated into a variety of care settings, including HIV service delivery, so that we can repair the damage and continue integrating and adopting newer methods of offering service delivery. So I think that's my last slide. I think the last one is an acknowledgement slide, just to acknowledge those who supported the work and preparation of this slide. And so having said that, allow me now to introduce our next speaker. And basically, as we work to identify and address the inequities facing children, youth, and families in the fight for an AIDS-free generation, it is important that we recognize the voices and the contributions of young people in all our efforts. So indeed, I'm honored to introduce an extraordinary youth activist from Lesotho, a lady I admire so much, and that is Dee Mpafintaka, who will talk about the necessity of including adolescents and young people in our efforts to end HIV. So welcome, Dee. We look forward to your remarks.
Good morning, good afternoon, and good evening, everyone. My name is Matapodi Mpafintaka, as Judith has introduced me. I'm going to talk about the necessity of including young people in decision-making, like she has said. Firstly, I'd like to thank all the sponsors and partners that are making it possible for us to go through the journey of fighting an AIDS-free generation. Adolescents and young people are the future generation of the world. And it is therefore necessary to include us in the policies and the decision makings that are made for us. Like we said since 2018, that nothing for youth without youth. And knowing that decisions were done with the involvement of young people who are going through the challenges that we go through as young people, the decisions becomes more compelling and doable for young people to do, and will reduce the new infections that have been increasing, like Dr. Angela and Dr. Judith have been saying about pregnant and breastfeeding women, and the increase of, or the decrease of infants taking ARVs. So it came to my attention that pregnant and young and breastfeeding women lately are young people, the adolescents and young people who are on ART or who just started ART on their pregnancy during their ANC visits. So it becomes very overwhelming for them to be pregnant, to be knowing that they are HIV positive, and at the same time they know that there is someone who is coming on the way who relies 100% on them to be healthy and alive. So it's a bit overwhelming for them, especially when they don't have the psychosocial support or the support that they need at home, in the community, or in their family themselves. So I think this would really help when we have young people included in the decision makings or in whatever that is being done, to make sure that we are also capacitated to continue with all the innovations that are being done to end AIDS, and we are able to step down the information to the upcoming generation in a more engaging, in a more less technical terms, in a more interesting ways, in a more youthful ways, and that way we'll be able to convince these young people to take their medications. We'll be able to tell them the importance of taking care of themselves, and we'll be also having enough information to render or to remove the myths that are being posted in social media on how people cure HIV, on how people have different herbs, on how people pray for people to heal from HIV. Because it's not so long ago when I got a comment from the picture that there was a challenge started that it was said to normalize HIV. So you had to post a picture and tell you're positive and stuff. So I had a comment there when someone was telling me that she is cured from HIV and I should stop taking my medication. So you could just imagine if the comment was done to a person who just tested positive, to a person who have less information about HIV, to a person who can go to the next facility, get tested, and they did not know they were HIV. I mean, their viral load is undetectable, and then they test negative. Those persons are going to say they are healed, and they're going to start their ART. So it's very important for decision makers, for policymakers to involve us in whatever they are doing, so that we are able to be capacitated and to be able to give factual information to other young people out there, so that they know that the grounds where they stand. And now that it's COVID, so many things are happening. There are less engagement in the facilities than they were back before COVID-19. And with social media, we'll be able to give the information that is that they could not get from the facilities, or that they could not get when they are at home, when they are with other peers. We could also keep on building those apps that will be less costly in terms of data, so that they're able to get information, so that they're able to ask questions in the same app and get people who are able to answer them at once. I think that's it for me today. Thank you.
Dee, thank you so much for your remarks, and thank you to each of our panelists for your demonstrated commitment, your expertise, and your insight into the ways that we must address the inequities in the global AIDS response during this time of COVID-19. Each of you is a remarkable leader in the global health community, and EGPAF thanks you so much for your tireless efforts. I now want to introduce the Foundation's own President and CEO, Chip Lyons, who will moderate our question and answer segment for today's event. Chip, over to you.
Thank you, Rhoda. Let me just start out by really complimenting each one of the speakers. Those were outstanding presentations, specific, very detailed, very focused, and I think really help us advance the appreciation of where we are on the pediatrics agenda and in light of COVID. So just really impressive, each and every one of you. Thank you very much. Angeli, if I can start with you, the comments I just made certainly also apply to your remarks. I don't think I can stress enough just how encouraging your comments were, doubling down, dedicated focus on peds and so on. I was originally thinking of asking you about, how PEPFAR is using an inequities lens, but I think you've already spoken to that in really specific ways, which is quite helpful. But can you, where do you see this going? What are the biggest implications of this shift or increased emphasis on inequities, certainly as it pertains to pediatrics? How does this play out? What are the implications for PEPFAR of a real use of an inequities lens for different population groups, but specifically also for kids?
Thanks so much, Chip. And, I tried to really, focus in, as you noted in my remarks, about how important really bringing in an equities lens will be as we move forward. And I think just to stress a few points in response to your question, as we are getting to this state of countries, getting to epidemic control of HIV and needing to sustain that in the wake of COVID-19, because that's still ever present. It's really, really imperative that we look even deeper at the subpopulations at the community level to really zero in on where do we need to go to tailor services specifically. What do we need to do differently? What do we need to do to be bold to really close those gaps? And so it's helpful that that we, together with you and all the others that are actively working to implement these robust HIV programs, are looking at data in a very granular way to really understand where the gaps are, what age groups, just like we heard in the previous presentations, what specific age groups the issues are, so that we can target our investments there. I think the last thing that I will just say that's changing the way we are doing business is, we are not going to be able to move the dial on some of these entrenched inequities that exist without shifting how we approach addressing program and policy barriers. And that is going to be, I tried to talk a little bit about this in my remarks, but that, the structural drivers for some of these barriers, the barriers related to gender inequities, the barriers related to, decriminalization in some populations. I mean, these are bigger issues that we have to tackle together in order to serve those in greatest need. And so that's something we're actively going to be moving forward on as we look to the future.
Thank you, Angela. I noted, if I recall, you in your comments also had emphasized re-engaging with governments and with ministries. And you have provided a lot of leadership over the last period of time, for which I suspect you didn't ask for, and you certainly didn't know what was coming. But thank you for that. And if and when, I think it's when there is a newly confirmed PEPFAR ambassador, I think that engagement is essential. And were Dr. John to be confirmed, I think he's rather almost uniquely placed to do exactly what you're talking about. and find the ways to address those program and policy barriers by engaging with government. So I appreciate your emphasizing some of the structural problems. I want to link a little bit your comments to Angela and her presentation, which was quite striking to me. Angela, I loved how you unpacked the stack bar analysis, and you identified 3 areas, which I think is exactly what Angeli is talking about, is being very specific and in some cases being bold. You have 3 ifs there. If we do this, if we do that, I don't remember exactly which one they are, but you've got a slide on that. And with those 3 ifs, the vertical transmission rate would drop to 1.58%, I believe was the very specific number. That sounds exactly like what Angeli is calling for, is really interrogating the data, really focusing, doubling down, and have a dedicated focus on those areas that are most resistant to change. Angela, are there program and policy barriers in the way of those ifs? Is that exactly the kind of focus and support from PEPFAR that can help in Zimbabwe to address those ifs and move in the direction of a 1.58? I'm going to remember that number, Angela, for a very long time. 1.58% in Zimbabwe. You heard it here first, but there are some ifs there. What did you hear in Angeli's presentation that gives you hope around addressing those 3 ifs?
Well, I'm very glad that Angeli spoke before I did, because I could hear very clearly that, you know, PEPFAR has like shining a spotlight, you know, on EMTCT, on pediatric HIV, on viral load suppression. And I do know locally back home here that there is a push also for scaling up pre-exposure prophylaxis in pregnant and breastfeeding women, particularly the adolescent girls and young women. And really for me, those are the touch points. If I can just elaborate and say from a policy perspective in our country, we know that we started pre-exposure prophylaxis mostly targeted at key populations. But now we have to scale it up to embrace other subpopulations. And I think that we should not miss the pregnant and the breastfeeding population, because you saw how when we were unpacking the stack bar, just by implementing PrEP, you can cut off quite a significant number of new HIV infections in children. Now, what that does by preventing new HIV infections, you know, mothers remain negative and they will give us a baby that is negative. We have a retesting policy, and I think that's critical. Once you have a mother within the pregnancy period and they test and they are negative, or they are in the breastfeeding period and they test they are negative, we shouldn't say goodbye to them. We must remain engaged in care. We must retest them at regular interval. And in our country, we have a policy for retesting women that initially test negative in pregnancy or breastfeeding. So we can pick up the time that they seroconvert, and then we can start interventions. And of course, I mentioned PrEP. We now have a policy to roll out pre-exposure prophylaxis. And now we are also scaling up viral load testing so that pregnant and breastfeeding women can get timely viral load, and we can action, particularly where you see that retention and adherence is a problem. The last one I think was, you know, those women who actually don't come. They don't come into ANC, but they are positive. So they are not put on ART. Or they come into ANC, they test they are positive, but they are not put on ART. And some of those reasons are really structural. The gender dynamics, the issues of non-disclosure, and we have to tackle those. So I really believe that we mustn't just program as we have always programmed, but that we must have nuanced programming that targets some of these areas for us to reduce our mother-to-child transmission to less than 5%.
Angela, thank you. It sure sounds to me like you and Angeli are on the same page in terms of where we need to focus and the emphasis being placed on that anew. So thank you. Angela, I'm going to come back to you for one more question before moving on to Judith and Dee. And that's just to pick up on your remarks that included COVID. There was a great, you very much emphasized continuity of service, the even scaling multi-month dispensing is a really important example. And I think there was an exclamation on a point on one of your slides about not reverting back to the norm, particularly in that area. But as it comes to COVID, one of the issues besides supply is uptake, distribution, vaccine strategies, and so on. There's a considerable amount of vaccine hesitancy across the country, frankly, in our country and in other countries as well. There are pockets of folks who lack confidence or who lack access to accurate information about the importance of being vaccinated. Are there further steps or roles you see PEPFAR playing in relation to a COVID vaccine that, for example, could include investing in the kind of communications and support engagement of communities to address hesitancy, to increase a demand for the vaccine? Is that something down the pike? Are you still trying to find more ways to leverage PEPFAR for COVID?
Thanks, Chip. And that it's such a critical question. And my response would be yes, yes, and yes. You know, I have to say, we already are doing everything from, like I noted in my presentation, we're really trying to push, and we've been pushing for the past over year and a half to really do everything from using the PEPFAR platform to do everything from COVID screening, testing, infection prevention and control, purchasing of PPE, readying the facilities, even all the way through to vaccine preparedness, readiness, and getting vaccines into arms, administration of vaccines. So we have opened the floodgates. We've been opening the floodgates. I think what we need to do is again, just continue to have conversations around the globe around what is the art of the possible. We have some great examples that I've seen in Zambia, for example, of how they've been fully leveraging the PEPFAR platform on addressing vaccine hesitancy, preparing the workforce that we support, and then the uptake of actually getting vaccines into arms. So I think it's a matter of, there's certainly resources that have been required. We've reprogrammed over the years, and then we've invested the additional $250 million from the American Rescue Plan that has been absolutely critical, but we can and should be doing more. And I think this is really a matter of communicating across countries, and actually we're planning right now just to have webinars just to communicate even more clearly what is permissible, because we are all in. We are all in. We have to really make sure we continue to bring everything to the HIV response and to the COVID-19 response by leveraging the platform, because without it, those gains that we've made in HIV are just we're in a really fragile state. So it really is about bringing everything to bear, which we're prepared to do.
Angeli, thank you. My takeaway is you're all in. And occasionally I do get asked questions posited by someone else, or an argument someone else is making, which is, I'm oversimplifying to make the point, don't involve PEPFAR. It's going to reduce services and so on. There needs to be a separate, and I get asked what my reaction to that is, and I keep coming up with delusional. That is not possible. It's not wise. And I'm really encouraged, and I thank you for leading PEPFAR into that place, pushing back. Presumably you also get those kinds of comments and questions as well, and pushing back on them because there is enormous leverage and possibility. And we are not going to get beyond the edge of the first generation free. I like that quote from Secretary Blinken. COVID is a gravitational pull away from that edge. And so I think your approach is really very important. And I appreciate you articulating and emphasizing that again today. Judith, if I can turn to you, you did a great job in your comments and unpacking the double trouble, I believe is how you characterized it in terms of kids and making the case for kids and so on. I just would like you to say a little bit more for anyone at a ministry level, at a partner level, at a donor level that understands, views the situation as you do, as children being particularly vulnerable and facing this double trouble. What are the first 2 or 3 things, they share your concern, they're in a position of authority around policy or spending. What's your advice? They call you and say, Judith, help us. What are the first steps we as a community should be taking to repair the disruption caused by the COVID-19 pandemic? What would you do if you were in that chair? What's your advice?
Yeah, thanks, Chief. So I think the effort to repair disruption caused by the pandemic, like you said, has in the recent past been described as building back better. And this basically would imply improving domestic health systems more generally, and so my advice would be, because the COVID pandemic represents a health system shock of unprecedented levels, to the point that there's a need to build a resilient health system. And a resilient health system means a system that's able to absorb the shock, able to adapt, and able to transform to cope with the shocks, to ensure that the health services and the health function continues to serve the health goals of the population. And so the other thing to remember is that to strengthen a health system for it to be resilient requires substantial long-term investment and capacity development. So unpacking what this means to ensure that we are changing. And while different governments may want to do this, and we know that one size doesn't fit all. There are many health systems that have tried to improve this, and so there's room to learn from one another and adapt. And when you talk about having a resilient health system, it means improving, for example, the service delivery, being able to triage better, having alternative methods of service delivery, home-based services, telemedicine, and healthcare workers that can adapt to the new normal, improving the infrastructure so that you adapt pathways both for COVID and non-COVID patients within the healthcare system, improving the supply chain so that products are available and are being used efficiently, things around securing and reallocating financing, because financing is a key element. And the most important is governance. So the foundation and the leverage for health system functioning is proper governance. And as you know, governance, without proper governance, you'll have poor policies, poor structures, and all this around this. So basically, it brings the attention for the importance of really this ministry is trying to reimagine the healthcare systems. What would really work, to address some of these disparities and the disruptions that we have had. Thank you, Chief.
Judith, thank you very much. You know very well, and you did a great job in your presentation of identifying where we are with kids and the challenges and so on. And you included points about the disruption from COVID. You know very well, not everything can be blamed on COVID. Things that stalled pre-COVID. I want to ask you just what's your frame of mind right now? We had stalled before COVID. Problems have been exacerbated by COVID. We need to make a number of adjustments because of COVID, many of which you just itemized and described. On the other hand, we know, and others know, and Secretary Blinken knows and said that we're at the edge of the first generation free. Are you optimistic? Are we at an inflection point where we can move forward on pediatrics and get rid of the stall, re-energize, revitalize? Where are you in all of this?
I'm very optimistic, Chip. So I think while we know that COVID so you're right, we had stalled in the reduction of new infections before COVID, and I think COVID has worsened it. But I'm very optimistic. Like Angela mentioned, some of the issues around new pediatric infections is maternal ART use and maternal retention in care and poor viral suppression. And so one of the things that makes me optimistic is the fact that we are improving the treatment for women. So we are using DTG, including for women who are of childbearing age, and this has a high potential to, improve suppression and subsequently reduce the viral load suppression and reduce transmission. So that makes me optimistic. The other thing that makes me optimistic is that by and large, we are beginning to see countries use data, granular data, to inform their services. So like Angela mentioned, the stack bar analysis really guides on where to focus for each country around elimination. So the fact that we are seeing that being done more within countries and other partners gives me hope. But I think the last point I wanted to raise around this is the country ownership and political commitments. So this has been key, and this momentum should not wane, COVID or no COVID. And so when I talk about country ownership and political commitment, I'm looking at the resources countries are putting in. And this is both financial and healthcare worker capacity, infrastructure. And an example is the Zimbabwe AIDS levy or the investment South Africa has done into HIV treatment. And so this country ownership and political commitment is key. It's progressing, and when you think about people in our programs, many times when they're doing HIV planning and target setting, they are doing it to the ministries. Ministries are taking over this effort, to adopt these guidelines and policies. And so countries are beginning to do this. I agree they can do more, and so there's need to keep a spotlight on this issue so that the effects can be felt more and more. Thanks, Chief.
100%. Thank you, Judith, very, very much. Dee, just maybe 2 minutes. We've got 5 minutes left, 4 minutes now, and we're going to have a hard stop at the bottom of the hour. Dee, you are very effective and convincing about the importance of listening to and involving young people, adolescents, in policy and formulation and so on. So the first order of business, as you characterize it, is nothing for us without us. However, once you're there, what do you think is the most important thing policymakers are going to hear or learn from you and others in trying to respond to HIV in this time of COVID? What's your key message? What do you most just wish you could get into people's heads when they're making policy or program decisions?
Oh, thank you, Chip. I just wish it would be as easy as we speak, really, because it's a bit difficult to tell an older person on how to do their jobs. So I think they would understand that we are more in the future. Our youth is not the same as theirs, and we do things differently nowadays. And it would be, it's not that we want to remove them from their seats. We want them to capacitate us so that we are able to understand the innovation, so that we're able to disseminate whatever they want to give in a better or revamped way, in a useful way, in a way that people would understand more. Because really, if we are given things that we are not able to do, for instance, we are still trying to implement the community adherence groups for young people in the country. So it's a bit challenging for us because young people still have difficulties in disclosing. So if we have if we're part of it, maybe, or if we would go into the villages, capacitate other young people so that they are able to help us give people how important it is to disclose, how important it is to have other young people who are HIV positive to support you. It would be easier that way. So I just wish they could hear us when we say things that you do are a bit old-fashioned for us to adapt. So it becomes less interesting to adapt in them. And then we increase the new infections, we spread HIV, we don't take PrEP, and then things just go south.
Dee, you're right. It's a generational issue to some extent. And it is a challenge. I didn't mean to make it sound like it's very straightforward and easy. If it was easy, it would have already happened. But I just wanted to put the spotlight back on the importance of listening to your generation from a practical point of view. When you're looking at vaccine rates or initiation on treatment rates or retention rates and so on, it only makes sense to learn from those of a generation that are most affected by this. And so please keep up the great work that you and your friends and colleagues and community are doing. I'm going to end us now because we're just probably 30 seconds from the close by thanking our panelists. I think, as I said before, each one of you just did an outstanding job, specific, clear, actionable, very much forward-looking to energize the pediatrics and adolescents agenda. That's exactly the kind of leadership and expertise we need. You all displayed it dramatically this morning. We are at an inflection point, and we just need to make sure it's all of our jobs to make sure this is positive and productive inflection point, so we move in the direction that we need to go over the next several years. So on behalf of EGPAF, let me thank all of you who participated, those of you who spoke, and thank you. This is an important week with World AIDS Day on Wednesday, and I think we've started it off in an outstanding way. Thank you all very much.